My name is Jason Satterfield. I'll be your speaker again for today. This is our third of 5 days of seminars, and today's topic is self-destructive emotions. Tomorrow will be social intelligence, and we'll have a half day on Friday, and we will return to chronic disease and medical symptom management. Just to give you a little bit of a sense of where we're going for today, we're first going to talk about emotion basics, so we're going to go over a little bit of terminology, not to get too bogged down in semantics, but want to make sure that we're using our language in similar ways. We're going to move quickly into talking about neuroanatomy and neurophysiology. I have found it much more interesting for most folks to talk about living, working brains inside real people instead of looking at lots of slides of brains. So we're going to talk about real people, and we're going to talk about real cases, and we'll flip back and forth between neuroanatomy and neurophysiology that way. We're going to break again for lunch at 11:30. Remember, lunch is catered, and I'm told that the Indian food caterer from Monday is back for today. Very good food. After lunch, we will start back promptly at 12:30, and we're going to start back with an exercise that you won't want to miss. If you miss the beginning of it, you sort of just miss the exercise. So we'll start right back at 12:30, move on into emotional intelligence. We'll talk about mental illness and cognitive behavioral therapy with a focus on depression and post-traumatic stress. We'll then move into sort of a broader category and talk about stress, the effects of stress, different programs to help us manage stress more effectively. And we'll end the day by talking about a relatively new field of positive psychology, and we'll talk about spirituality and its relationship to health and health care. A lot of the same shopkeeping for those of you who have been here before. Just remember that if you haven't picked up an evaluation form, you need to do that before the end of the day, hand it in at the end of the day. I love this to be interactive. We do lots of exercises. We also take lots of questions, so feel free to ask questions. The day's pretty packed again today, so I won't be able to get to all of them, so my apologies. Please remember to turn off cell phones, pagers, squeaking, squawking, beeping things. That would be much appreciated as well. I do see lots of familiar faces from Monday, but I'm wondering, with just a show of hands, who was here on Monday? Most of you. Okay. So if I'm remembering from Monday, we had a majority of nurses in the audience. Is that so right if you're in nursing? Okay. Psychology? Okay. Counseling, social work? Okay. About our same mix. Wonderful. I wanted to start with a few caveats because I think the title maybe isn't as informative as it could be or should be. I first want to say that this is not the Don't Worry, Be Happy seminar. I'm not saying that we should all be happy and that's our ultimate goal, that we should only have positive emotions. Negative emotions are important. They convey potentially important, potentially life-saving information, so we need to have them. We need to be able to understand them and to use them appropriately. Our goal is not to eliminate all dysphoria, but to understand it and to learn when it is constructive and to learn when it is destructive. If it is destructive, then how do we change it? How do we manage it? How do we turn it down, if not turn it off completely? We're going to focus most on the individual, so we'll do a lot of self-reflective type exercises, a little bit of dyadic exercises. You'll think a little bit about your family of origin, but we're really going to focus mostly on the individual. And I did want to say that, of course, when we talk about emotions, the expression of emotions, that culture is critically important. We'll talk about it a little bit today, but we really don't have the time to go into a lot of details about different cultural rules about emotional expression. The major emotions we're going to talk about today, and this is not to say these emotions are always self-destructive, but they certainly can be at times. We'll talk about anger, and we'll especially talk about hostility and cynicism. We will talk about depression, and more about clinical depression as a medical disease and not about the normal reaction to loss or grief. We will talk about fear. We will talk about shame. And I want to contrast what I mean by shame versus guilt. In general, someone feels guilty when they believe that they've done something wrong, and they feel bad about it. They feel guilty. When a person feels shamed, they believe they are something wrong. It's something about their identity that they are ashamed of, not just something about their behavior. We will also talk about chronic stress. We'll talk about situations where it might be helpful and actually improve functioning, and situations where it can be damaging to our health. So as I mentioned on Monday, I'm a faculty at the medical school at University of California, San Francisco. I'm a psychologist, but my appointment is in internal medicine. So we do a lot of mind-body work there, a lot of working with students and with residents. Part of the charge of our team of mental health providers is to support the mental well-being of the students, the residents, and also the faculty. These are very smart, very ambitious, sort of high-functioning folks that oftentimes don't want to take the time to look at their own health or their own wellness. So we've developed a number of different programs, and one of our programs is regular support groups that are confidential, and a lot of times are even off-site. And it's a place, really a space, for these sort of developing physicians to begin to learn more about themselves and about their emotions and to try to cope with the stress of medical practice. We've been doing this since 1996, actually, and I've been struck by how these same myths or these same ideas emerge again and again and again from each new crop of students and residents that seem to come through. And I've written down just a few of these because I think some of us might hold those as well. So the first is we're only supposed to feel good. So if you're at work and you feel bad, if you're with a patient and you feel bad, if you're in your marriage and you feel bad, then there must be something wrong. Not necessarily true. I'm the only one who feels this way. So you imagine that you're the only one who feels anxious, incompetent, uncomfortable, unhappy, when in fact that may be a feeling that is created by the environment that you're in, and everyone is feeling the same way. Most people don't have problems, but I do, so there clearly must be something wrong with me. Recently heard from a medical student, and we have about 150 or so med students per year, and the med student pulled me aside and he said, in all seriousness, he said, "You know, I think I'm the one accidental admission." And it was a thought that, unfortunately, I've heard from dozens of other students of, you know, I'm the mistake that the admissions committee made because I'm having a hard time and I'm feeling bad. Other myths, I can work through it on my own. I think that's probably a product of our culture. Be a cowboy, be strong, be independent, pick yourself up by your bootstraps. Just roll your sleeves up and work a lot harder. Don't show weakness, don't show vulnerability. And the last myth, and we'll talk about this more towards the end of the day, is that mental health is simply the absence of mental illness. And while it's true that a lot of psychology, a lot of psychiatry, a lot of mental health is really mental illness, there is a whole different aspect to human being, to human functioning, to human emotions that isn't about illness, it's about health, and we should think about ways to promote that. So we're going to come back to these three cases again and again over the course of the day today. The first case is a case of Eve. She has issues of alcohol abuse. She's clinically depressed and she's recently divorced. Case of Charlie, he's a classic type A personality. We'll define that a little later. He's often angry, emotionally detached, and chronically stressed out. And our third case is the case of Sybil. She was recently sexually assaulted. She has anxiety. She wonders if she has post-traumatic stress disorder. And she has a lot of shame and a lot of anger as a consequence of what happened. Before we talk about mental illness, before we talk about maladaptive or destructive emotions, we should just talk about emotions in general and what they are and why they are there. In general, I think of emotions as data, not necessarily verbal or linguistic data, but they're a source of information that tell us something important about ourselves, about our relationships, or about our environment. We feel a particular emotion because it is designed to either push us closer to someone or something, or it's designed to push us away from something that might be a threat. So a feeling like love really draws you closer to a person. A feeling like fear or anxiety really pushes you further away. So when you're getting that signal, when you're receiving that data, the question to ask yourself is, what sort of information am I getting, and what is it telling me about myself, my environment, or my relationships? We also believe that even though some will talk about the rational brain and the emotional brain, and we'll sort of talk about different brain areas a little bit later, the two are actually very, very closely related. In fact, there used to be, people used to use the metaphor of the brain as sort of a filing cabinet, and whenever you wanted to retrieve a memory, you'd just pull open the right drawer and sort of pull out the right file. We know that that's actually not the case. Even if we sort of update it a bit and say the brain is a computer and you just retrieve the right file, it doesn't work that way. In fact, when we're laying down memories, they're very much influenced by our emotional state. When we're retrieving memories, they're very much influenced by our emotional state. You may have had the experience before with a very old friend or with a parent or maybe an adult sibling. You're recalling an event from 10, 20, 30 years ago. You were both there, but you remember it completely differently. It's not because one person's smarter or has a better memory than the other person. It's because your emotional state was different at the time it was laid down, or your emotional state is different at the time of retrieval. So it's important, as we're recalling things that have happened, that we take a step back and remember that our accuracy rate, even when you're not depressed or unhappy, our accuracy rate actually isn't that great. We also believe that emotions may be universal, and I'll show you some of the research there, and we'll do a replication of some basic research around this notion. We know that emotions are body-based, so there is a physical sensation. Some people are very aware of what's going on in their body when they have an emotion, and others are pretty unplugged from their body and aren't so aware. I will try not to confuse emotions with feelings, but honestly, every time I've given the talk, I slip a couple of times, so I just want to put it out front. Emotions, when we talk about emotions, we mean that more sort of basic, universal, body-based information that we get. When we talk about feelings, that's a much more complex and complicated level. Feelings are emotions, but we've attached memories, images, music, beliefs, all sorts of cognitive material gets attached to the emotion, and that's more about feelings. And feelings are, of course, much more influenced by your family history, by your story, by your culture. Okay, so emotions versus feelings. It's important to remember when we talk about emotions, those of you who know cognitive behavioral therapy will recognize this triangle. We have emotions here at the top. We know that they're intimately related to how you think and what you do. We have bidirectional arrows because that relationship goes both ways. How you think affects how you feel and what you do. What you do affects how you think and how you feel, and so on. Question?
Could you just
Right. So feelings. Sure. So feelings versus emotions. Feelings are more complex than emotions because it's not just the physical sensation of having an emotion. It's how you interpret it. It's the memories that get triggered. It's images that come to mind. It's music or memories, things that are attached to it. So it's all of that rich cognitive material, sort of that higher cortical functioning that gets attached to the more basic emotional sensation.
Thank you.
Okay. So here we're going to come back to this triangle over the course of the day, classic cognitive behavioral therapy triangle. We'll talk about it in the context of treating mental illness, but also of just managing stress. All right, so if we take the viewpoint of emotions as information, they're neither good nor bad. They are signals, really. They are attempts, our body's attempts, our brain's attempts to tell us something that might be important. I like to think of emotions as a sort of weather report. They help us, hopefully, help us to prepare for what might lie ahead. They're not always accurate, but really the effort, the intent is to help us prepare for either good or bad weather that's ahead. Why don't we do our first exercise then? If you can turn to the back of the slides, this is a similar setup to Monday. There's a group of exercises in the back, and I'm going to ask you to take just a few minutes to fill out exercise number 1. Exercise number 1 says self-assessment. Which emotion do you have the most difficulty expressing? What are the clues or signals that tell you you have this emotion? What inhibits you from expressing this emotion? Okay, so what emotion is difficult to express? What are the clues or signals? And what inhibits you? I'll ask for just a couple of volunteers, and we're going to come back and we're going to work on this emotion throughout the course of the day. So how about a couple of volunteers? What emotion do you have the most difficulty expressing? When she feels disappointed or hurt by others, what are the clues or signals that tell you you have this emotion? So you physically feel sort of a pulling back. You feel a tightness in your chest, okay? And what inhibits you from expressing this emotion? So I don't want to make the other person feel bad, and I want to protect the relationship. What actually happens is it stalls the relationship. Okay. How about another example? So all the way in the back, what emotion do you have the most difficulty expressing?
That would be sadness.
Sadness. What are the clues or signals that tell you you are sad? Difficulty breathing and you don't sleep very well. Okay. Any other sensation in your body, your muscles, your posture, your face? Okay, tightness across the upper back goes into back pain. What inhibits you from expressing sadness? So fear of, I guess, infecting other people with the sadness, fear of being vulnerable, and fear of other people not understanding. Okay, all right. One more, yes? Sadness or fear? Okay. How about we'll pick one of those and tell me what it feels like in your body. What are the clues or signals you have? And is that fear or sadness or both? Okay, so for both, he feels physically weak and your stomach tightens up. What keeps you from expressing those feelings? You twist it into anger. Comes out. So sadness and fear come out as anger. Okay. And I would guess there's some rule or some belief that anger is more appropriate to express than sadness or fear, or more comfortable. Okay, all right. Did anybody put anger down? Okay, other people put sadness or fear? How about a positive emotion? Joy, happiness, love? We're going to be coming back to this emotion over the course of the day. You can change your mind and work on something else later if you want, but we will be coming back to that emotion, both in terms of understanding where you learned how to express it and how you might learn a different way to go about expressing it in the future. Before we go there, I wanted to lay a little bit of the groundwork on some of the foundational research that's been done looking at emotions. We mentioned this idea that emotions were universal, meaning that people all across the world in all countries with all levels of education, all levels of industrialization, they have the same basic set of emotions. This was not a given. We couldn't really make this assumption until someone went out and actually did the research. That someone was Paul Ekman. He is also a psychologist. He's also at the University of California, San Francisco. He started doing his research in the 1960s, and he wanted to answer this question of whether or not there is a core set of universal emotions. Clearly, there's variation due to language and culture and so on, but is there sort of a core set of primary emotions that everybody has just because we're human? That was his question. Now, obviously, he couldn't go to all these different countries and interview them because they would just, it would be in their own language. They would have different words for emotions. There would be a lot of subtleties that you wouldn't get. So he thought probably what would be easiest to do is not look at verbal communication, but to look at nonverbal. And in particular, what he was most interested in looking in was an individual's face. He wanted to look at their facial expressions. Now, face is very complicated in terms of its musculature, but every human, regardless of their physical characteristics, their size, their color, their race, their ethnicity, they have the exact same facial musculature. We have the same capacity to make facial expressions when we're feeling an emotion. So he decided a way to circumvent language and culture is to look at facial expressions. So he got his graduate students to make a series of different facial expressions, when you're feeling sad or frightened, and he snapped a photo and created a portfolio. He took a portfolio of all these facial expressions on this grand tour around the world. Now, he couldn't ask, what emotion is this, what emotion is this? People have different languages and different words. He did ask them, however, tell me a story about what just happened to this person. Again, it's not about the labels you put on emotions, but it's something that happened. Would there be a universal reaction that would cause that particular facial expression? So he takes his portfolio, he goes to Central America, goes to South America, goes to Europe, goes to the Middle East, goes to Australia, and he ends up in Papua New Guinea. There were tribes people there, and really no education, no technology, no industrialization. And he shows them this exact same portfolio to see if emotions are universal. So I thought what we would do is I would show you some clips from his portfolio. You could take the same, at least part of the same test that the folks in Papua New Guinea took, and we can see if it's similar for you guys. So turn to exercise 2. Yes, question. Right, so the question is, they're all women, and save that one until we get through the exercise, and we'll talk about some of the pros and cons of his methodology. That's a good point. So if you can just turn to exercise 2. It says Ekman facial expressions. You'll see 6 numbers. What I'm going to do is show you 6 pictures. And rather than writing down a story, because that takes too long, just write down the emotion you think that person is trying to convey. So look at the picture on the screen and write down the emotion you think that person's trying to convey. And then we'll go back and we'll check. Okay, so here's exercise 2, picture number 1. Write down the emotion this woman is trying to convey. Picture number 2. What emotion is she trying to convey? Picture number 3. What emotion is that? Picture number 4. Picture number 5. And the last one here is picture number 6. So what emotion is she trying to convey? Okay, so let's go back up to the first one. And let's see how your responses compare to the folks in Papua New Guinea. So this first expression, what emotion is this? So happiness, joy, most people have, that's fairly easy for them to read. The tribes people in Papua New Guinea said she just had a healthy baby. She's very happy. How about this one? Disgust. So again, fairly easy to read that one. For the folks in Papua New Guinea, she just stepped on a rotten pig. That sounds like disgust to me. But this one? Sadness. Her baby's very sick. This one? Fear. She's being chased by a wild pig. Apparently there are pig issues in New Guinea. This one? Angry. Her friend broke her best pot. How about this one? Surprise. Someone startled her. They jumped out from behind a bush and startled her. Okay. So you can see from a fairly quick and easy exercise, it's not too hard for us to read the same sorts of information. Methodology was a little bit different. They told stories instead. But again, still, it's not that hard to see that we're approximately on the same page in terms of reading those facial expressions. Ekman agrees, and he argues that there were 6 primary emotions, and we just went through those 6: happiness, surprise, sadness, anger, disgust, and fear. Of course, there are a lot more emotional terms. There's a lot more emotions and feelings, really, that people have. In fact, in the English language, there are 552 different words for kinds of emotions. Lots of different kinds. He makes the analogy to painting or to art, where there is a very small set of primary colors, but the artist can blend and shape and mix those colors in an almost infinite variety for a lot of very different subtleties and shade and saturation and brightness and so on. So we have our 6 primary emotions, and then there are approximately 500 plus blended emotions, depending on what culture and what language you happen to speak. There was a comment earlier about the pictures and the fact that they're all female. They're also all Caucasian. You could probably tell, too, it's fairly dated from the hairdos and so on. What he was essentially trying to do was to just control for those factors. So they either had to be all male or all female. He wanted them all of one particular race or ethnicity. He wanted them all of approximately the same age. So he didn't want the variability to be because of differences between the models that he used. I don't know why he used women instead of men. I guess I could ask him, but I never really thought about that. Of course, facial emotions are just one way of expressing communication, and they are oftentimes masked, or they are changed, or our cultural demands tell us that we have to express an emotion that we might not be feeling. A good example would be if you are talking to your boss, you might want to appear interested. If you're at a cocktail party and you're actually kind of bored and unhappy and don't really want to be there, but you also don't want to be impolite, you will act like you're interested and maybe in a better mood than you actually are. As Ekman's work began to evolve, he started to ask himself, well, how can we tell if a person is faking an emotion or not? And again, he went back to the facial expressions. People become very good at verbally or using language to tell lies and fibs. So he thought it might be harder to trick your face. And if a person's very good at reading subtle facial cues, maybe he could break through someone's poker face, essentially. So first what Ekman did was to memorize all of the facial musculature, and he also trained himself to be able to independently move every single muscle in his face. So if you see him, you can walk up to him and say, Paul, 24, 42, 36, and he'll distort his face, those 3 muscles, he numbered them all, into some very bizarre expression, and everyone has sort of a good laugh. He's great at cocktail parties. But really, the purpose of doing that was to try to catalog what a genuine facial expression looks like versus a fake facial expression. And probably the easiest one to spot is when a person is faking being happy, because there's really just one primary muscle that's the most important. It's the orbicularis oculi, so it's the muscle right in the corner of your eye. And if you are genuinely happy and smiling, it's not just about your mouth and the smile, it's about this muscle contracting. And actually the sides of your eyes will squint a little bit. You'll get those crow's feet or laugh lines, and they'll squint a little bit if you're genuinely happy. If a person's just looking at a camera going, geez, nothing happens up here because they're not genuinely feeling that emotion, they're just faking it. He was able to develop a similar methodology for almost any emotion, and in fact, he got so good at doing that, he was contracted out to the CIA, and he started going to various sort of negotiations and watching videotapes of world leaders and speeches, and he would tell whether or not the person was being sincere, if they were telling the truth, if they were conveying the exact same emotion. Interestingly enough, and probably on purpose, he was never asked to look at videos of our own leaders. So what I thought, again, of rather than giving you sort of a list of different kinds of nonverbal communication and talking about how important it is, and of course it is, I wanted to give you an experience of what it's like to manipulate the nonverbal signals that you are sending. So I want to turn to the next exercise. This is exercise number 3. It's called the pairs blank wall. You will find a partner. One of you will be a talker, and one of you will be a listener. The talker will talk for 2 minutes about something fun you did this last week. It doesn't have to be a big deal or private or anything, just something fun you did this last week. The listener, your job is to be a blank wall. No smiling, no nodding, no talking. You can make eye contact, but you do absolutely nothing. You'll go for 2 minutes, then you'll switch. The talker becomes the listener becomes the talker. We'll go for another 2 minutes, okay? So 2 minutes are up. You should switch now. The talker becomes a listener and vice versa. Okay, so your 2 minutes are up. So why don't we hear first from the perspective of what it's like to be a listener in this exercise. So what is it like to be the blank wall? So it's hard. Why is it hard? So you want to respond and you want to show interest. So she had to stay disconnected physically from what you were thinking. She had to think about something sad. So it was hard to stay connected if you weren't sending signals. If you think about it, it should have been easy, right? So you were asked to do nothing. Just sit there. So even though she didn't want to react, it was hard to shut things down completely. Her eyes were still sending some signals. Yes? Right, so it's hard to listen, it's hard to concentrate, hard to follow. How about for the talkers? What was it like to be a talker? Seems like the other person's not interested, and you start to feel yourself getting a little bit frustrated. When I've done this exercise as a talker, I think, okay, I'm going to crack that blank wall. I'm going to start making stuff up, and start telling crazy stories, and eventually they start laughing. But you do feel this impulse of, hey, wait a minute, I need to get something out of you. How about other talkers? Yes? Right. So I think especially for therapists, where that's sort of our life work is in communication and connection, and especially in a dyadic pair, if you do individual therapy, it's hard to hold that back and not do it. Yes? Right? So you feel frustrated because the other person isn't responding. Exactly. Right. So it should have been fun to be a talker, right? You're talking just for 2 minutes, so not a lot of pressure. You're talking about something fun you did. You're bringing back a good memory. But instead, it turns into this frustrating experience. And really what we've done in just a couple of minutes, 4 minutes, is to demonstrate how saturated even our simple social interactions are with this nonverbal communication. It feels very bizarre not to send any signals. And it feels very frustrating or confusing or just unfulfilling not to get any signals back. We are innately wired to send these signals. Some of us hone and improve those innate skills. Some of us maybe have experiences that make us less able to send or to receive or to accurately interpret those nonverbal signals. We'll talk after lunch about a construct of emotional intelligence. That's certainly part of it, partly innate, partly learned. But the bulk of what will be talked about tomorrow, social intelligence, is really about those signals, the saturation of those signals that we often share unconsciously but are so critical to our relationships. Yes? Right. So Botox may work for wrinkles, doesn't work for your relationships. It really does not help. So we're going to talk about a variety of emotions, and it's important to remember emotions related to how we think and what we do. Emotions have a function. They send us information. But different emotions, they have sort of a different function. They have a different theme or a different meaning that is typically tied to them. For anger, it tends to be a perceived violation, injustice, or a frustration of a wish or desire. So something that was rightfully yours was damaged, taken, and denied. People typically feel angry. Happiness, the perception or expectation of gain, and this doesn't have to be material gain, it can also be symbolic. Anxiety or fear usually has two things. One, there's a perception of a threat. There's something dangerous that's out there, and that's coupled with doubts about your ability to cope with it. So if there's something dangerous, but you know you can manage it, you don't feel too anxious. If there's something on the horizon that looks pretty scary and you're unsure if you can step up to meet that threat, you feel anxiety and fear. Sadness, and here we're talking about normal sort of everyday sadness, is the perception that something of value has been or will be lost. That could be something inside you, that could be a relationship, that could be your job, it could be anything, any kind of loss. So where exactly do self-destructive emotions fit in? And really what we're going to wrestle with over the course of the day is really this particular question. All of the emotions we've talked about can be constructive and can be helpful. But self-destructive emotions become destructive when they have gone past the point of delivering useful information. They are pointless and unhelpful reiterations of the same information over and over and over again. For instance, worry can actually be quite helpful. It focuses our attention on a problem. We hopefully start to problem solve and to think about the ins and outs of the problem, the pros and cons of different solutions. But once you've thought about the problem, once you've done all really that you can do, continuing to worry is not helpful. It's a waste of energy. The same with anger. It may help you notice a violation, an injustice that needs to be corrected. After you've done all that you can do, continuing to be angry for weeks, months, years, sometimes even decades after an event has happened is just a waste of energy. It becomes destructive. So it's being able to decide for how long and how much is this emotion helping me learn, change, and grow versus it's a pointless or even hurtful reiteration of the same information over and over again. Someone who has certainly reached the point of having destructive emotions and even psychopathology is our first case, the case of Eve. She's a 41-year-old woman. She's recently divorced. She's a hospital administrator. She has no kids. She lives alone, and she is socially isolated. On average, she drinks 3 drinks per day. She occasionally has an eye-opener or a drink when she gets up in the morning before she goes to work. She occasionally has a drink during lunch, and she sometimes has weekend binges, and here a binge is defined as more than 4 drinks in one sitting. So she, I think by any accounts, she is a fairly heavy drinker, and we're going to worry about alcohol abuse for her. She meets criteria for major depression, and this is her second lifetime episode. As we talk about the neurobiology of this disease, you'll see why it's important to know how many episodes a person has had. It's very much related to their risk for future relapse. Most of you know this already, so I'm not going to go through this full list. But to meet diagnostic criteria for depression, you have to have 5 of these 9 symptoms, most of the day, nearly every day, for at least 2 weeks. Sometimes get questions about the second symptom, anhedonia. That's an inability to experience pleasure or joy, even from normal things that you used to like. We know that major depression is quite common. In fact, in our primary care clinic at UCSF, and from studies that we've done of our patients, we know that the incidence of depression is the same as the incidence of hypertension. So we tell our doctors if they are seeing many more patients with high blood pressure than with depression, they're probably missing a lot of depression. So we've tried to institute a number of different ways to screen every patient, essentially, that comes in for depression. As I mentioned, if you've had multiple episodes, your risk of relapse goes up. If you've had 1 episode, your risk of relapse is 50-50. If you've had 2 episodes, your risk of relapse is 70 to 80%. If you've had 3 episodes, it's more like 80 to 90% chance of relapse. And this is if you go off meds and it's untreated. So it seems to be really a chronic, repetitive disease that picks up strength as it moves forward. And we'll talk a little bit about what's happening in Eve's brain. Now, I wanted just to go on a slight tangent before talking about some basic neuroanatomy and physiology, because I think it's important that we have a shared rationale of why we want to look at all these funny Latin names for different brain areas and how that might actually impact your clinical care. So I think probably the easiest, the most superficial rationale is, well, we want to understand the physiology, the anatomy of a disease so that we can understand what causes it, understand how to prevent it, maybe think of new treatments. Absolutely true, absolutely important. The other reason, though, has to do with something called a patient's explanatory model of illness. We all have theories about why we're sick, about what it means, about what it says about us, our world, other people, what treatments we should have, and so on. The same is true, I would say especially true, for psychiatric illness or when there's not a clear cause of the disease. So an example comes to mind of a patient of mine. This is from a couple years ago. She was diagnosed with fibromyalgia. It's a chronic neuromuscular pain disorder. There's certainly a neuroendocrine component to it. We don't understand it that well. She also had depression, and she had a really bad case of chronic insomnia. So she actually came to our behavioral medicine unit because she wanted some training in sleep hygiene, and she wanted some behavioral strategies to try to sleep better. So she came to see me. We started working on her sleep. And essentially, she said, what happens is this. She will go to bed 10, 11 o'clock or so at night, and she goes to sleep just fine, not a problem. What she does is she wakes up in the middle of the night, usually about 3 o'clock in the morning, and she starts worrying about something. Okay, well, what is it that you worry about? And she sort of looked down at the floor, and she said, you know, this is me, this is my pathology, I'm just really neurotic. I wake up at 3 in the morning and I think things like, damn, I forgot to buy chicken. Or why did I not change the shoelaces in that shoe last week instead of having to do it tomorrow morning? Really, as she would say, minor, trivial, unimportant little hassles or things that would come up. They would come up and then she would get upset at herself for thinking about those kinds of things. And the more she got upset at herself, the more aroused she got, the further and further away from sleep she got, until pretty soon her alarm goes off at 6:30 in the morning. She hasn't fallen back asleep, and she has another exhausting day at work. Long about this time, while we're working on thought stopping and other ways to relax and usual insomnia type treatments, she enrolls in a study for fibromyalgia, and they were looking at cortisol, a stress hormone, and the pattern of secretion over the course of a day. It usually rises and falls, and we'll talk about that later. She goes into this study. She comes back to me, and she says to me, this is the happiest I've ever seen her, she says to me, I have a cortisol disorder. Looked at her, I said, okay, why does this make you so happy? She said, well, I've learned from this study that I have some sort of dysregulation of when my body secretes this stress hormone. Instead of having a peak at 8 or 9 o'clock in the morning like most people, guess when my body starts to secrete cortisol? 3 a.m. I'm waking up at 3 a.m. because my body, for whatever reason, is secreting this stress hormone, and I'm waking up and feeling agitated and uncomfortable and unhappy. I'm not waking up because I'm neurotic. I'm not waking up because I'm a mess, because I need to be fixed, because I'm self-defeating and I'm sabotaging myself. There's something wrong with the stress hormone. She had the same disease. There's not really a way to reach in and change when her body secretes cortisol. So her symptoms were still there, but her explanatory model of her disease had changed. There was less self-judgment. There was less condemnation. There was less depression because her explanatory model changed. And I think when we turn to brains, we turn to neuroanatomy, we turn to neurophysiology, we're able to provide patients an alternative explanation for why they have those symptoms. It's not an excuse. It's not a behave badly and don't worry about it issue. It's a matter of helping them find an explanation that's not so self-pejorative and so self-condemning. So we'll do a quick run-through of areas of the brain. Here on the left, this is looking from the outside. The eyeballs would be about right here. Over on the right side, they have made the outside of the brain slightly translucent, and we're looking through approximately to the center, and this is the limbic system. We think of the limbic system as sort of the basic center for the generation of most of the emotions that we have. In general, if you look at the brain, it nicely mirrors the process of evolution. So if you go further towards the center and further down towards the brainstem, it's a more sort of primitive brain. So if you look at a reptile's brain, it looks kind of like the brainstem and just this little piece here, maybe a little bit up into the center. If you go up the evolutionary chain a bit and say look at primates or monkeys, you start to see some of this higher cortical areas, but it's really only in humans that we have these huge frontal lobes, sort of the latest, most advanced part of the brain that gives us the capacity for higher thinking, for executive functioning, and we'll talk more about that. The limbic system is present in a lot of animals, so animals must feel some sort of emotion, maybe not feelings, but they must feel some sort of emotion. And I want to just point out a couple of different structures. The first here is the amygdala. It's a tiny sort of almond-shaped structure. You should think of the amygdala as the brain's homeland security system. So, it is designed to set off an alarm that tells you there is a threat that's somewhere present, or it is designed to set off an alarm that tells you you're going to have to get ready to fight. So it's this quick, dirty, often inaccurate system that tries to prepare you to face some threat that might be out there. I also want to point out the hippocampus that's here. It's very important in laying down new memories. To stick with the computer analogy, I think of the hippocampus as sort of the keyboard for the computer. So you need the keyboard to enter in the information into the computer. The thalamus here in the center, think of that as the sensory relay station. So any sensory information, visual information, auditory information, smells, they come to the thalamus. The thalamus often copies those signals and sends them to multiple different brain areas where they're processed in different ways. And when we talk about post-traumatic stress, we'll talk about how the thalamus plays a role in copying those fear-based memories and sending them into different brain areas. Okay. So I mentioned the frontal lobes. These are uniquely human. They are responsible for what makes us human. They are also the youngest part of the brain, and they're the last part of the brain to develop. In fact, there is a very good reason why teenagers act like teenagers. Their frontal lobes are not fully developed until age 25. So I think the rental car companies probably have it figured out. You can't rent a car until you're 25. So you want someone to have their frontal lobes so they can inhibit impulses, they can delay gratification, they can sit and more calmly and logically, rationally think through a decision rather than just acting emotionally. That's all about our frontal lobes. It's divided into a left and right frontal lobes, and especially in the prefrontal cortex, so the front of the frontal lobes. We know those are important for emotions. For the left prefrontal cortex, usually associated with more positive emotional states, so if a person's laughing, if a person feels very happy, if a person feels loved, you'll see more activation in the left prefrontal cortex. The opposite for the right prefrontal cortex, if a person's depressed, anxious, sad, upset, you see more activity in right prefrontal. Now, just to remind you from this picture, so here's prefrontal cortex here, here's the limbic system. These are very much connected to one another. The limbic system, the more primitive, quicker way of generating an emotion, but those connections to the frontal lobe can either dampen that emotion down or it can really escalate that emotion. Anger is a good example. Someone may say, cut you off on the freeway and you feel a blip of anger. Your frontal lobes then say, chill out, calm down. He's just in a hurry, just like you are. It really doesn't matter. And the emotion's essentially turned down and turned off. But it's really that relationship, that connection between those two that gives us the capacity to manage our emotional states. So, question? Right. So the question is, does this help us understand why teenagers feel invulnerable and invincible? And I can't say for sure, but I would say probably. Our frontal lobes help us in this decision-making process, or what are the dangers, what are the advantages, what are the disadvantages of realistically weighing the possible implications of a decision. So it is sort of careful, measured, structured, rational way of approaching the world and making decisions. So I would guess it's related. I don't know if anyone studied that for sure, but I would guess so. Yeah. So the question is about early life trauma, and if someone has early childhood abuse or a traumatic event that happens, does that affect brain development? Yes, it does affect brain development, not so much the frontal lobes as the limbic system. So we'll talk a little bit later about the hypothalamic pituitary adrenal axis. And for a child who's been abused, essentially the sensitivity of that system is turned up dramatically. So they will tend to have elevated cortisol throughout most of their life because the sensitivity of the HPA axis has gone up as a consequence of having a trauma early in life. We'll get to that a little later. The question is, what about teenagers using drugs in large quantities? Okay, so if teenagers use drugs in large quantities, will it affect the development of the frontal lobes? We would guess so. Again, I don't know of any data that proves that. Probably the absence of development contributes to the bad choices that they're making to use drugs. Depending on the drug that they're using and the amount, you may see some neurotoxicity, not just in frontal lobes, but in other areas too. When we get to substance abuse, I'll show you some pictures of different of the nucleus accumbens and sort of how it devolves as a person uses more and more cocaine or methamphetamine. Okay, so let's look at some neuroimaging. And again, just to remind you, we're trying to think of what's happening in Eve's brain. She has an addiction to alcohol. She also has depression. For depression, you see a couple of different findings if you look at pictures of a depressed person's brain. Overall, their brain shows less activity than healthy controls. It's almost like someone dimmed the lights in a depressed person's brain. You see decreased activity in left prefrontal, increased in right prefrontal, which makes sense knowing what we know about the frontal lobes. You also see increased activity in the amygdala, the homeland security system, so a person's much more sensitive or much more likely to misperceive threats in their environment. So here's a SPECT scan. It essentially measures the amount of blood flow that goes to a part of the brain. As the brain becomes more active, it requires more blood. Blood brings glucose, which is the energy really the brain needs to work. We have a couple of different series of pictures here. This is just from one person, a person who is not depressed on the left. On the right, we have a person who is clinically depressed. They have taken horizontal slices through the head, and they essentially compare slice for slice from the left to the right groupings. Levels of activity are reflected in the type of color. So the hotter the color, so like these white hot colors or orange colors are more activity. The cooler colors are less activity, so these purples and blues are less activity. So if you compare slice for slice, you can almost see, not in every single one, but in many of these, that there is less activation in a person who is depressed versus a person who is not depressed. We don't really know why that is. We used to explain depression by saying, well, it's about neurotransmitters. A person gets depressed because they don't have enough serotonin. And in fact, a recent study we did looking at some of our residents and our medical students, when they tell a patient that they're depressed and they do some education, they still tell them that. It's a chemical imbalance, and I'm going to give you this pill that will restore your chemical imbalance. Sort of, kind of, but not really true. And the reason that's not true really has to do with how a person responds therapeutically to an antidepressant. Person comes in, they're depressed, they do indeed have lower serotonin, maybe dopamine, maybe norepinephrine, a mixture of other neurotransmitters. You give them an SSRI, say like Prozac, Paxil, Zoloft, something like that. They take the pill, and right away, their serotonin levels go up. But you don't see a therapeutic response until 4 to 6 weeks later. So if it was just about restoring chemical balance, why don't they get better the next day after they start taking the antidepressant? Clearly, there's something else going on. It's not just about levels of serotonin. Now we know it's much more complex than that. It actually has to do with neuronal growth and neuronal functioning. It's related to levels of serotonin because depending on the chemical pool that your neurons are in, they will grow more or they will grow less. So we believe now when you take an antidepressant, it's responsible for the release of something called neurotrophic factors. Think of them almost as vitamins for neurons. They help with the process of arborization. So there's the dendrites, they grow more branches. They have more receptors on those branches, so they're more likely to be able to receive or to send a signal. The effectiveness of the receptors that are there is improved. It's much easier to conduct an electrical signal in those neurons because of the neurotrophic factors, those vitamins for neurons. Guess about how long it takes for the arborization, for the reforestation to take place. It takes about 4 to 6 weeks or so. So we believe that's part of what's going on. We're looking, too, at genetics. They call them blue genes. We're looking at genetics because it seems that some people are especially sensitive to stress, meaning when they become stressed, the genes that are responsible for creating, say, accurate or well-functioning receptors for serotonin get turned off. So somehow, neurologically, as a consequence of gene activation or gene deactivation, they show more damaging effects to stress than others show. Kind of a theory right now, kind of hand-waving right now, but we believe that might help us to understand why there's a hereditary component to depression and why two people can have the exact same stressful event. One gets clinically depressed and the other does not.
Is that the epigenome? Is that what you're talking about?
The epigenome. Not exactly. So if there's a subfield of genetics called epigenetics, and they look at brain behavior interactions. Well, actually, it might fit within epigenetics. It's a person is born with these pre-existing vulnerabilities. That's not epigenetics. But if those vulnerabilities are turned on as a consequence of something happening in your world, then that would fit. That does fit. Right. So, yes. So the hope is you could create therapies, biologic or talk therapies that could also turn those genes on or off and create a therapeutic effect. That's the hope. I think we're kind of far from that right now, but that's the hope. Okay. This is just to show you where most of the serotonin pathways in the brain are. You've probably noticed this looks an awful lot like the limbic system. There are also projections. These are hard to see because it's white on white, but there are projections into the frontal lobe. Serotonin's not the only player, but it's certainly a key player. If we're looking at cognitive behavioral perspective of Eve's depression, this is just a reminder. It's not just her brain. It's not just her emotions. It's also how she's thinking, and it's also what she's doing. When we talk about treatment for her a little bit later, these are our two primary avenues of interventions, what she's doing and what she's thinking. Now, she doesn't just have depression, she also has substance abuse. And we have a little bit of a chicken and the egg kind of problem here. So we don't know if she's drinking because she's self-medicating her depression, or if she's depressed because she's been drinking so much. And in fact, it's maybe a little bit of both. We certainly see that picture frequently. Just as a reminder, substance use disorders are divided into both abuse and dependence. With dependence, you see hallmark features such as tolerance. You need more and more of a substance to get the same effect. And you see withdrawal. Certainly with alcohol, it can be life-threatening. So if a person is a chronic heavy drinker, you don't want them to stop cold turkey without some sort of medical management. We also know substance abuse is quite common. For alcohol, we have about 5 to 10% of men and 2 to 5% of women. Statistics tell us that about a quarter of us have a family member with an alcohol problem. And honestly, when we do the genograms with our medical students and our residents, it's more like 85 to 90%. I don't know if we just have a selected sample of folks that come into med school or something's up with our admissions committee, but it's more like 80 to 85%. Around 40% of college males meet criteria for alcohol abuse. And those numbers, although lower for women, they have been rising fairly dramatically. Alcohol seems to be a big part of undergraduate college culture. We believe about 50% of addiction risk is due to genetics, and it's important to remember that. So if you do not have a substance use problem, you shouldn't congratulate yourself too much. You've maybe made some good choices. You've maybe been in an environment that supported the healthy use of alcohol. But a lot of it, too, is, again, the genetic roll of dice. Are you just physiologically, genetically more vulnerable to developing an addiction? So what are those areas of vulnerability? It has to do with our innate reward systems, and there's two, and I'm just going to focus on the mesolimbic dopamine system. The other is our system of endogenous opiates. So we have sort of our own natural painkillers. People will talk about the runner's high or these opiates that get released. It gives you sort of a warm, pleasant, satisfied kind of feeling. That's endogenous opiates. Dopamine is different. It is released to teach us that something is desirable or to push us closer to something or to someone. It's called the pleasure chemical, but not because you get high if you take dopamine. It doesn't feel that way. And dopamine in your brain is designed to teach you to seek something out. And we know that if you seek that something out over and over and over again, you're essentially laying down a new neural pathway that tells you alcohol is good, alcohol is what you need. Chocolate is good, chocolate is what you need. We believe that neurons that fire together wire together. So neurons that fire together wire together. Now, we used to think sort of way back when neuroscience was starting, your brain was pretty much all wired and finished by the time you're 5. We know that's not true. In fact, all throughout your life, you are breaking and forming new neural connections. So where is dopamine? It is throughout the brain, but I wanted to point out a couple of different areas. Here, just behind the limbic system, the ventral tegmental area, and its projections to the nucleus accumbens. You can see that it sits in front of the limbic system. It's closer to the frontal lobes. Essentially, when a person uses and reuses a drug or something that brings them pleasure, you are really reinforcing the highway, the relationship between these two different brain areas. They can exert an effect on the limbic system. They can exert effect on the body. You may have experience either with yourself, family members, or patients when they even just have a mental image of the drug or the alcohol or whatever it is they are addicted to. Changes the way their body feels, their blood pressure goes up, their heart rate goes up. They start to have those cravings. It activates memories about the use. It affects their emotional state. Really what's happening is dopamine is hijacking the brain, essentially. It's important to remember that it also exerts an influence on the frontal lobes. So a lot of times you will hear someone with a substance abuse problem saying, when they're sober, this is not me, this is not who I want to be, this hurts me, this hurts my family, I'm not going to drink again, I'm not going to drink again, it's not going to happen. They leave your office and that night, somehow they drink again. And it can be incredibly frustrating, I think, especially for family members that believe the person isn't serious, and then maybe they're being insincere, maybe they're just lying. It's really not it. It's their frontal lobe saying, okay, when I think about this rationally, it's not the right choice for me. I don't want to do this. But their nucleus accumbens getting activated. They have this superhighway that says, frontal lobes, I'm switching you off. We're going to go get a drink. And that's exactly what happens. So the role of dopamine in that process is if you take cocaine, methamphetamine, something that gives you pleasure, it's dopamine that's released. It's a neurotransmitter. Dopamine causes you to feel that desire, that motivation, that craving to go towards something. It also changes brain architecture in that it starts building this relationship, this highway, between the VTA, the ventral tegmental area, and the nucleus accumbens. Right. Exactly. So the activation of those dopaminergic neurons play an important role in an individual's craving, and those cravings sort of overwhelming their higher cortical functioning. Okay. Yes, in the back.
Is it true that violence or violent people have increased dopamine level? Because I have read something about it.
Okay, so the question is it true that people who are violent have higher levels of dopamine? And I don't actually know. I haven't read anything about that. I'm not sure. Yes?
And what activates the external cues that activate this dopamine?
Right, so the question is what activates this whole system, and a lot of times it is external cues. So an early part of many substance abuse programs, even for nicotine, cigarettes, for other things, is to remove those environmental cues. So you get rid of the pipes, you get rid of the paraphernalia. Even better, you sort of move to a different apartment. You want to get rid of all those external cues that are going to remind you of substance use. Well, let's look at what happens to the nucleus accumbens as a person uses more and more of an addictive substance. Here's the nucleus accumbens. Again, these are horizontal slices of the brain. The orange areas are more activation. And here we're looking at activation, but we're also looking at receptor density. So we're looking at dopamine receptors. And the more orange they are, the more receptors they have. So here's a person who's alcoholic. You can see that there's little tiny orange spots of receptor density. A person who's not alcoholic, you can see there's actually these big strips of much more dense receptors. This is a person who has binge eating disorder, so really their drug is food. And you can see some deforestation, some pruning of receptors. Again, you see a big difference with the normal. On the cocaine, though, is probably the most dire picture. There's zero orange on there at all. And here, again, in normal, you can see that there are some orange slices. So essentially what happens is because of taking this substance, you're forcing your brain to release these massive amounts of dopamine. Your body, which tries to keep things in balance, is saying, whoa, way too much dopamine. This is not natural. This is not right. I'm going to start chopping off receptors so that I don't get so stimulated. What happens is a person develops tolerance. Wait a minute, I'm not getting high anymore, so I have to take more and I have to take more. The body responds by cutting receptors more and more and more. So they're in this vicious cycle of damaging their brain. Here's a picture of someone that was using methamphetamine. Here's the normal control. You see the orange areas. Here's the meth abuser. You can see it's even a little bit worse than cocaine. So there really is pretty substantial damage. Here, this is a person who had been abstinent for 1 month. Not a small accomplishment. Same person who had been abstinent for 14 months, so a little over a year. You can see that the orange areas have actually come back. And I actually show this picture to some of my patients who have had this addiction because they're oftentimes worried that they have permanently damaged their brains. And I usually tell them, yes, it is true that your brain has changed as a consequence of your addiction. And yes, it is true that you will never go back to having a drug-naive brain. It just doesn't work that way. However, our brains are much more resilient than we once thought. There's a lot more neuroplasticity than we once thought. In fact, if you're able to stick with this a year, 2 years, maybe even as long as 5 years, we can still see that there are some improvements in brain functioning if you're able to stay abstinent. So there is a reason to have hope. Yes. So the orange is level of activity, but it's also a reflection of receptor density. We're looking at dopamine receptors. So what you're seeing is not just an area of the brain that's less active. You're seeing a pruning of receptors because there's too much dopamine as a consequence of that addiction.
So you want to have a lot of dopamine receptors.
You want to have a lot of dopamine receptors.
And with the smoker, do they have, because I understand that dopamine is released with nicotine.
Right. So the question is, how about with nicotine? There is some dopamine released with nicotine, but not the same quantities as you get with methamphetamine or with cocaine. The same is true if a child is on a psychostimulant. There's some dopamine that's released, but again, it's a much smaller amount. For folks who are using cocaine or methamphetamine, because of tolerance, they keep using more and more and more. I know because they don't have receptors, they get tolerance, they want more of an effect. And in fact, if you talk to some methamphetamine abusers, they're using 1 gram or 2 per day, which is a massive amount. Nowhere compares to a psychostimulant that someone would take therapeutically. Yes? So what's the picture for opiates? So remember, we have 2 different brain reward systems, the mesolimbic dopamine system, and that's really what we've been talking about. Then there's the endogenous opiate system. So you wouldn't see sort of the damage to nucleus accumbens or to dopamine receptors with endogenous opiates. The effects are much more global, and they're in different areas. So you would see some effects on basal ganglia. You would see some of the effects in the pain centers of the brain. And this one isn't about opiates, but this shows you where the basal ganglia is. We are in Northern California. I get lots of questions about marijuana. So I put this picture in too to give you a sense of where marijuana works. Marijuana also helps for pain control, stimulation of appetite. It's not tapping into the endogenous opiate system. In fact, our body naturally has its own cannabinoid receptors. I did get the question last time, why do we have cannabinoid receptors? And I don't actually know. That would be a great thing to look up, but I don't actually know. But we do have cannabinoid receptors, affect our basal ganglia. That's important for things like motivation, energy, coordination. We know it affects the hypothalamus, in particular the hunger center. So it is true, people do indeed get munchies if they smoke marijuana. It affects the cerebellum. That's important for motor coordination. We believe that there's some effect on memory. Again, that's the hippocampus. Remember, that's the keyboard that enters data. For people who have chronic and heavy marijuana use, they can sometimes have anxiety or some paranoia, so there's probably some amygdala involvement in that as well.